So my name is Chantal. Oh, the title of my presentation, as you may have seen when you signed up, is Exploring the Person-Centered Care Practice Patterns of Mental Health Nurses in Newfoundland and Labrador. I'll be talking about my mixed methods research study that I am doing for my PhD dissertation, and also just a little bit about, person-centered care as it pertains to mental health in the background of and how I'm looking forward to expanding on my work and those sorts of things. So, all right. So what is person-centered care? Person-centered care is a central pillar of high-quality healthcare. I'm sure you've heard the term before many times. It's been linked to improved patient outcomes, satisfaction of care, as well as job satisfaction for nurses. Patient-centered care has been endorsed by many health organizations in Canada, like the CNA, and also our provincial regional health authorities, which is now becoming, or is just one. Person-centered care, as defined by the WHO, is an approach to care that consciously adopts the perspectives of individuals, families, and communities, and sees them as participants as well as beneficiaries of trusted health systems that respond to their needs and preferences in humane and holistic ways. So, defining characteristics of person-centered care. Although the definitions of person-centered care have varied, there isn't one, common, definition for it. The defining characteristics in the literature are pretty much the same, no matter who's writing about them. They talk a lot about working with persons' beliefs and values, engaging authentically, shared decision-making, being sympathetically present, and working holistically. And when we talk about engaging authentically, for example, we're talking about practitioners engaging in a very genuine way with others, like being their natural self, for example, being present with the service user. When we talk about being sympathetically present, how that's different. It's like taking time to listen and find out what's important to the individual, for example, paying attention to their needs and not just the immediate task at hand. So, they are what typically is defined as the characteristics of person-centered care in the literature. There's many frameworks that have been outlined regarding person-centered care. The one that I find particularly useful was developed by McCormick and McCants, which are two researchers in the UK, and this is a schematic of sort of the framework that they have developed regarding person-centered care, and it is the framework that I've used to guide my research. So when we think about person-centered care here in Newfoundland and in health systems, and in the case of what I'm looking at in mental health, systematically throughout our health regions, and nationally, there are many reports saying that health organizations practice person-centered care. But there's little evidence publicly available, at least in our health regions, that describe outcomes of person-centered care in our health systems. It very much appears that the landscape of person-centered care in the province is yet to be mapped. And in order to advance person-centered mental health nursing care, which is what I'm interested in within the province, I feel like more data is needed regarding current person-centered practices that currently exist. Of course, I focus on nurses because I am a nurse, but person-centered care is applicable to all health disciplines for sure. So before I go on and talk about my research in specifics, I want to just look at this framework a little closer, because the variables and concepts throughout my research very much relate to this framework. So as you can see there's an outer circle, prerequisites. So these are the prerequisites that nursing staff in my case of my research would hopefully be possessing in order to move in toward the next circle and then the next, and to eventually see these positive patient outcomes. So we're talking about prerequisites like being professionally competent, developed interpersonal skills, commitment to the job, clarity of beliefs and values, and, for example, knowing self. So these are things that we would hope that practitioners would embody. And then If that is strong, then it would support a person-centered environment. Now, nurses in and of themselves or health professionals in and of themselves cannot uphold person-centered care environment on their own. Obviously, there are organizational structures that need to be in place for that as well. So when we talk about the care environment and what needs to be in place in terms of person-centered care, we're talking about things like allowing staff for potential for innovation and risk-taking. We're talking about the physical environment that staff are practicing in. We're talking about power sharing among health professionals. So our nurses' opinions being heard at the table among other health professionals. Supportive organizational systems is another important aspect of the environment, especially from the from the perspective then of the organization providing those systems and structure to allow nurses to provide person-centered care. Effective staff relationships is very important. Shared decision-making systems and appropriate skill mix. And so when all of these things are in place, then we can more likely and probably move to our care process, which is the delivery of person-centered care, which we talked about these in the previous slide: engagement, shared decision-making, sympathetically present, holistic care, and working with patients' beliefs and values. And then if we're providing person-centered care, the idea is that these person-centered outcomes would persist, like satisfaction with care, involvement with care, patients' feeling of well-being, and creating a therapeutic culture. All right. So what's the problem? I mean, it all sounds well and good. Person-centered care sounds like a lovely concept. Canadians, for example, as well as I said before, healthcare organizations, as well as healthcare providers themselves, all think that person-centered care is a priority, place value on it. In fact, most healthcare organizations in Canada have endorsed practice models that place patients at the center, Eastern Health included. But my question is, do we really? Maybe some practitioners practice person-centered care as best they can while working in the confines of policy. But as an organization, can we really say that we're providing person-centered care? Certainly in the inpatient setting, no matter what care model we are saying we're working within or practicing within, our ways of working largely currently very much follow a medical model, right? We may have aspects of our care that are centered around the patient, but our hospitals are largely run on a medical model. What's important to remember about person-centered care is that developing a person-centered culture is not an isolated event. It requires sustained commitment, both from the health organization and from individuals like nurses. That is to say, in order to provide true person-centered care as an organization, there must exist a commitment to developing person-centered cultures within which we work and care for others. That doesn't come easy. In fact, it takes a huge commitment from the organization as well as the people who practice within the organization to cultivate person-centered cultures. In a few slides, I'll talk about what contributes to a person-centered culture, but person-centered cultures are fragile in any healthcare system, in any healthcare setting. Mental health and addictions has compounding obstacles to delivering person-centered care. Things like certification, poor patient insight, community treatment orders, fragile family and social supports. Such unique issues add complexity to the provision of person-centered mental health care, particularly regarding principles such as working with people's beliefs and values and shared decision-making. What is more likely occurring are person-centered moments versus person-centered cultures at this point in time. Think of times in practice when everything seemed to be coming together and outcomes feel satisfying and rewarding. We all have memories like those, such as a significant event with a patient, a meaningful moment of support offered by a colleague, feedback offered from a leader that was intentional and empowering. These are moments that contribute to person-centered cultures. Such person-centered moments may trigger the question, why can't it be like this all the time? And let's get it right now. These issues are not unique to our health system here in Newfoundland. Many and most health organizations struggle to develop person-centered cultures. And I think one reason for that is because they're not achieved by one-off change events. As I said before, it is a sustained commitment by organizations and individuals. And that takes a lot of work and a lot of time. So as many of you know, my area of practice is mental health. I've been a casual float in the mental health and addiction system for 10 years, and recently also a educator with Memorial. I have a huge amount of respect for the great work that everyone does in our mental health and addictions program locally. However, I also believe we should always be looking for ways to advance and improve. During my time as an inpatient nurse, one thing that was apparent and bothersome to me was that there was a lack of opportunities for nurses to enrich and develop their nursing practice. I can't tell you how happy I am for the Sierra NL to have opportunities like this so that, so that nurse can, have enrichment of their practice through these sorts of webinars. I hope more initiatives within the health authority, like the research day that we're going to have on Friday, become available to nurses. However, examples that are unique to the mental health inpatient system are far and few between in my experience over the past 10 years. My research interests ultimately lie with enhancing and advancing mental health nursing care in the province. I want to contribute to building a culture within the mental health and addictions program in our province that is person-centered. And a big part of how I can contribute to this work is by working with nurses through practice development research. I will always advocate for organizational change that supports person-centered cultures. And I know that person-centered cultures can't exist without strong organizational commitment, but building nurses up has always been my focus. My first initiative was started with the Mental Health Nursing Journal Club that I started about 3 years ago. Some of you may be familiar with that. This provides a basis for evidence-based practice. So about 4 years ago, I did a focus group with some mental health nurses in our inpatient program. When asked, what informs your practice? They said, other, more senior nurses. Very few, if any, of the 19 nurses involved in the focus group said that research informs their practice in any way. They felt that they weren't given the opportunity to read research or incorporate new ideas into their practice. Now, we all learn from our peers. That's a good thing. That's not a problem. But if we only ever learn from those our senior, then how can we advance mental health nursing practice? That gave me the idea for the journal club. And that isn't to say that research is our only source of knowledge either. But the point is, ideally, we use many forms of knowledge to inform our practice. I want to continue to work with nurses to enrich and advance how we practice. And so, because I'm only early in my academic career, I created this study that I'm going to talk to you about for my dissertation that essentially lays the groundwork for future research. Findings from this research will inform the direction of my future research. So I wanted to look at the current person-centered care practice patterns exemplified by mental health nurses in Newfoundland and Labrador, so that I may see where we could focus, or I could focus my efforts in future for helping to advance and enrich practice. So 6 research questions that I developed were, what are the self-reported person-centered care practices of mental health nurses in the province? To what extent is the practice environment we practice in associated with the delivery of person-centered care? What occupational, environmental, and demographic factors predict nurses' delivery of person-centered care? What are the occupational and demographic factors that predict a person-centered care environment? What is the nature of the tertiary patient care culture as demonstrated by some unit observations? And what are the person-centered care perspectives of individuals who have received mental health nursing care in the past 6 months at the inpatient level? My study was a mixed method study concurrent mixed method study, that is. For the quantitative methods, it was a cross-sectional electronic survey. If you are a mental health nurse, hopefully you received an invitation to participate in that last year. Registered nurses in Newfoundland and Labrador were all invited to participate. I did recruit to the CNRNL as well as through the health organizations. The survey that I distributed included 3 questionnaires: the person-centered practice inventory, which was developed in alignment with the framework that I just discussed in previous slides; the person-centered climate questionnaire, which also was informed by the framework; and then 13 demographic and occupational questions that I collected, that I made up myself. So the findings that would have answered the research question, what are the self-reported person-centered care practices of mental health nurses, my first research question. So I had 70 responses from nurses across the province. I had more, but I had 70 usable responses, that being that there was enough data. There was hardly any missing data from those 70, and so I took those. And I did have representation from each of the regional health authorities, which was nice to see, and I'm happy about that for sure. I know that we're all one now, but at the time I did, so it was we weren't, so that was nice. So this is a breakdown of the 3 components of the framework that align with the one of the questionnaires that was in the survey. So the prerequisites, the environment, and the person-centered process. These numbers are difficult to compare because they are scored. The tool is organized in such a way that they are not comparable to one another unless you reduce them down to like a percentage or something. So when you do the math, the person-centered care environment was ranked the poorest, if you will, but everything actually was rated relatively high overall. Just comparatively, the person-centered care environments were rated the lowest by nurses. Now we have, if anyone here is in my journal club, I always tell people, to look at results critically and those sorts of things. We have to remember a few things in this survey. First of all, individuals rate themselves high, period. We as nurses, not just nurses, but anybody, but we as nurses, want to provide excellent care, and not to say that we don't, but certainly the typical trends of questionnaires is that people do rate themselves on the higher end. So that's one thing to just have a critical lens with these numbers. And also something else is that people who answer the questionnaire may have been people who were interested in person-centered care, or maybe people who do practice in a person-centered way. So, potentially the results could be positively skewed because of that as well. It's not a bad thing, of course. It's wonderful that the scores are so high, means that we do have excellent person-centered care according to the results of this survey. So the next research question: to what extent is the practice environment associated with the delivery of person-centered care? So I did a Pearson's R to determine the association between those, and there was a statistically significant positive association, meaning that as the care environment sort of scored higher on the surveys, so did the delivery of person-centered care. So that's a good thing, because obviously we would expect the environment and the delivery of person-centered care to be positively correlated, but we know that is the case for our health settings. I did some regression questions. What occupational, environmental, and demographic factors predict nurses' delivery of person-centered care? And I found out that the prerequisites predict delivery of person-centered care, the environment predicts the delivery of person-centered care, as well as relationship with managers, which was a demographic or occupational question I asked. So that came out as statistically significant in the model as well. And then when we looked at what occupational and demographic factors predict a person-centered care environment, both the prerequisites and the relationship with manager was also significant in that model. So just back to the framework again, I just put this slide up essentially so that we could, just get our mind around that one more time. So our prerequisite ring is on the outside, and then, our environment next in from that. And then we hope to be providing the person-centered care. in the inner circle. So I just want to refresh your memory on the model because it is so threaded throughout the study. So on to the qualitative research questions. What is the nature of the tertiary inpatient care culture as demonstrated by unit observations? And what are the person-centered care perspectives of individuals who have received mental health nursing care in the past 6 months? So for the interviews, I interviewed 8 persons who had received inpatient treatment for a serious mental illness in the previous 6 months. And for the unit observations, I did 36 hours of observation on 3 inpatient units at the Waterford Hospital. I shouldn't say I did it. My research assistant did it, but she was a registered nurse actually in the Waterford, and through different issues with gaining access to the Waterford and ethics and things like that, it was deemed to be the most appropriate sort of that a nurse that currently worked there collect the observations, and she did a wonderful job with that. The observations were collected using a tool, the Workplace Culture Critical Analysis tool, and that also was developed in line with the framework that we just seen on the previous slide. So again, very threaded through the study. In terms of the interviews, I interviewed 5 females and 3 males. 2 of the 8 were currently employed, 5 were between the ages of 20 and 30, 2 were between the ages of 30 and 40, and 1 was between the age of 60 and 70. The interview findings yielded 5 categories: the care approach to mental health nursing, perceived relationship with nurses, dependability of care, impressions of the care environment, and patient suggestions for improved person-centered care. I should say that the data analysis for the interviews was done for all the qualitative sections, actually, using Sally Thorne's interpretive descriptive methodology, and the method for data analysis was constant comparative method. So the first category, the care approach to mental health nursing. So we actually found that a lot of the interviews had said things about basic nursing care, or the interviewees had said things about basic nursing care, and then there was things about person-centered care. So there was a lot of basic nursing care comments, but we also highlighted some wonderful person-centered care comments as well. So interviewee number 2 said 2 nurses specifically who kind of like took the time to explain things to me, like why they were giving me meds. So that's that's basic nursing care, explaining to your patient why they're getting their meds, for example. But then we've seen also some more person-centered interactions, like interviewee number 8 said, she seems to really care, like she would come in and ask how I was, and she seemed to be able to anticipate my moods just by talking to me. And, I really appreciated that so much. And then another person said, I found even if I wanted to be up at 4 a.m. pacing the halls, the staff didn't mind as long as I was quiet. And I should also say that these quotes are direct, so sometimes they seem, maybe a bit like unaligned, but we have to take the actual quotes that they said. So the second category was perceived relationship with my nurses, and there were several subcategories with this one. So comfort level with my nurse. Someone said he was just very calm, cool, collected, and very comforting. The nurses were helpful when it needed them was another subcategory relating to perceived relationship with nurses. Interviewee number 4 said, one night I couldn't sleep at all and I was just having a rough time at the moment, and just had a talk with her, the nurse, and making me feel a bit better. And then another subcategory was I wasn't getting the care I wanted. Interviewee number 3 said, sometimes I was the one who would try to get a conversation going. And the thing is, it will be me at the table with the staff member who was supposed to be sitting there with me during the hour for any support I required. Another subcategory was feeling like nurses had authority over me. So interviewee number 6 said, I'm a larger male. Me expressing discomfort towards somebody or raising my voice at all could be grounds for them to call security on me or just try not to deal with me. So I find it difficult to express discomfort sometimes. Dependability of care was the third category. There were several subcategories here too. So the care I received was dependent on the nurse I was assigned. We had a lot of interviewees highlight this. One articulated particularly well and said, it's kind of a mixed bag as to whether or not you're going to get like a very empathetic treatment from whoever, for whatever it is you're experiencing. So I find it can be a bit of a toss-up. Continuity of care was another subcategory for dependability of care. Interviewee number 1 said, some days you might get the same nurse 2 or 3 days in a row, depending on scheduling. If the same nurse was working 3 days, then they would try to keep consistency. And then subcategory 3 there, the nursing care received different between sites and units. So we had several interviewees that were admitted on different units as well as different sites, like maybe health science psychiatry versus the Waterford. And so they said, when I stayed on one unit of the acute care units, I wasn't rushed at all. I was treated a lot better by those nurses than I was the nurses, say, on another unit. Knowing who was caring for me. So one interviewee said, I didn't know who the nurses were. So it was like, what do I do to get their attention? Who do I ask if I need assistance? Impression of the care environment had a lot of subcategories. There's this slide and then the next slide. So the first subcategory was availability of nurses. Interviewee number 3 said, if I was having trouble getting my anxiety to go down, there were several times I was looking for my nurse and either she was with another patient or she was onto another floor or something. And interviewee number 1 contrastly said, there was always a nurse available for me to talk to. Feeling unsafe came up a few times in the interviews. Interviewee number 2 said, the dynamics within the unit weren't the greatest. And some of the people kind of were intruding and scary at times. The physical environment was not helpful to my recovery. So interviewee number 6 said, I prefer to have less people in a room. There were times where we were constantly like wall to wall, multiple, like 8 beds into a room. We can't really reduce beds, but it would be nice to have some sort of separation there or some sort of privacy in that way. Interviewee number 1 said, all I wanted to do was get out. I just wanted space. I just needed space. There was no space. Okay, so the subcategories for the remaining subcategories were having access to activities was helpful to my recovery. Interviewee number 1 said, I did the gym every day, Monday to Friday in the morning, 8:15. And there were 2 days during the week that they do it in the evening. My God, we used to go down, and if I could get a couple people to go down with me, we'd play soccer and we'd play basketball. I went on all the walks and stuff I could. I really liked the OT program. Another subcategory was the hospital/unit felt comfortable, familiar. Interviewee number 1 said, I really got comfortable there. I really familiar with it. And then the final one for that category was awareness of nurses' stress workload. One patient said, you can hear them say to one nurse, oh, I'm supposed to be with that patient now in a minute. I don't want to. You go deal with him because he got me stressed out. Like I'm after hearing that 100 times walking in the halls. Patient suggestions for improved person-centered nursing care. So there were 5 subcategories here. Advanced therapeutic communication. So one person said, being able to communicate well is important to those acute situations that should be fairly tense. Nurses who are capable of de-escalating those situations without having to call security and stuff. Treating patients in a humanistic way. Someone said, kind of understand, try your best to be like empathetic with individuals, even if they are somewhat delusional in what they are perceiving around the world. They're still people and need to talk and to be sort of, at least you're trying to communicate properly rather than talking down to people and being condescending when you are in a strictly more sane state as a caretaker. Being sympathetically present, to be able to listen to what they have to say. Building authentic relationships. Interviewee number 1 said, take care of yourself first. Make sure that you're well rested for work. Bring your water bottle. Have clothes that are safe. But if you're tired from the night before or you've got other stuff on your mind, it's really hard to deal with mental health patients. And then tailored patient education. Interviewee number 2 said, I think especially in the case where I was having a mixed episode, just explaining everything and the reason I'm there and what I'm taking. So then that was the interviews. So then the observations, as I said, it was 3 units at the Waterford Hospital, and there was 12 hours observation each unit, 36 hours in total. Each time we used we did it for 2-hour observation periods at a time. So it was like there were 6 observation periods per unit, and each observation period used a new tool. And as I said, we use Sally Thorne's descriptive methodology and the constant comparative method for data analysis. So the results for this part of the study are still ongoing, but some preliminary results, very broadly speaking, our nurses appear to possess a lot of the important prerequisites to person-centered care, especially developed interpersonal skills and professional competence. Effective staff relationships were very apparent in the observations. We've seen staff working very well together. What we also seen was nurses spent a lot of time delivering care across the nursing desk rather than out on the unit or in private. We also seen that although instances of person-centered process, that being the delivery of person-centered care, were witnessed, it was not as often as we would have hoped. Patients seemed to have to seek out care, so come to desk for care. And from an organizational perspective, potential for innovation and risk-taking appeared limited. And what I mean by that is like nurses' preparedness to take calculated risks and utilize new ways of working. Promoting innovative care is another example for potential for innovation and risk-taking. And that makes sense because 4 years ago when I did a focus group, nurses felt that they, were limited in the way that, to be able to use research in their practice, they felt that was limited. So that there's no surprise sort of in that regard. The integration for the study is still ongoing. When we clue up the observations, we'll be continuing on with the integration. So that'll answer the broad research question, what are the person-centered care practice patterns exemplified by mental health nurses in Newfoundland and Labrador? And I wanted to just mention that the study was funded for $15,000 from 3 different funding sources, one of which was a Quick Start Fund. And for anyone who's not familiar, Quick Start funds are typically used to engage partners in the community. So what I did was I used that money to engage the Pottle Center in developing a partnership. I formed a partnership with the Pottle Center that resulted in the formation of an experienced expert advisory group. So 7 members of the Pottle Center provided their lived experience expertise to inform the study. And I was able to use that money to facilitate those meetings. So I met with them 4 times. All 7 members came to every single meeting. And we talked about mostly about the interviews and observation, but I reviewed the potential interview questions that I was going to use for interviewees. Make no mistake, these people were not participants in the research, but partners in the research. So they would guide, maybe change some wording in some interview questions, and I reviewed the findings with them from the interviews, and we talked about some of the analysis regarding that, and that is a key piece of health research, is being able to involve individuals with lived experience in the research process. So I was very happy to be able to do that. So looking ahead, as I said at the beginning, there are many benefits to improving our person-centered practice. Improved health outcomes for individuals and families, for example, as I mentioned before, is a big one, like increased self-efficacy, shorter hospital stays, better functional performance. In one American study, for example, person-centered care was found to significantly reduce the use of seclusion and restraints in inpatient adult mental health settings. Another American study examined the impact of person-centered care and collaborative documentation on medical adherence in mental health community settings. And medication adherence was found to be significantly improved in the experimental group there. As I said before, person-centered care improves job satisfaction of nurses, improves satisfaction of care received by patients. Although my presentation has been mental health focused, the concept of person-centered care applies to all areas of nursing and all areas of healthcare for that matter, such as social work, for example. Some of you may work in the community and feel that you have had a great deal of autonomy compared to those who work in the hospital. Maybe you feel you are mindful of your practice and prioritize the importance of person-centered care, regardless of where you work. If you're an individual or a team who are sort of checking off all the boxes I'm discussing here today, then give yourself a pat on the back. But remember, developing person-centered cultures is continuous. So good for you, but keep it up. Or maybe this presentation has caused you to pause and think, am I really practicing in that way? Has my practice become stagnant or complacent? Then I'm glad that I could help you recognize that and now maybe work towards enhancing your practice. I'm not sure if everyone here works in mental health or in inpatient mental health or where you work to, but I know that from my research study, as well as from my own experience, that mental health teams deliver excellent care. There's no doubt about that. But a lot of the time, it might not be person-centered, especially in the inpatient area, and that's for a variety of factors. And that does not mean the care we provide currently is bad. It means we have room to advance and enhance. And I realize staffing levels play a factor at times, but not all the time. And I realize that burnout plays a factor, and that's where the organizational commitment comes into play. Supporting health professionals to provide person-centered care is essential. Once my study is complete, I hope to conduct future work with nurses and health organizations to assist us in moving forward toward person-centered cultures. I'm not sure that we could ever fully say that we practice within a full-fledged person-centered culture because it's almost a little bit unattainable, if you will. But we need to work toward it as much as we can because it is for the betterment of everyone really, but most importantly for patients.